It's my real pleasure now, as our last speaker, to invite my co-chair, Professor Shoham, who not only was co-chair, but also tremendously helped us in the organization of this conference. And he will address yet another controversial issue, and that is the endometrial scratching.
Good afternoon. Thank you, Norbert, for creating such an interesting congress and allowing me to present some of the data that we generate during the years. I was given the topic, what is the real evidence that endometrial injury improves IVF outcome? And before going deeper into the presentation, I just want to ask you how many people here are actively involved in doing IVF? Thank you. And how many of you are think or doing endometrial scratching to improve implantation? So almost the majority. So my task is very easy. Okay, first I have no relevant financial relationship to disclose. And let's go to implantation. And I think it's most important when you implant a new technology to understand what is the physiology behind it and why we are doing it. And if the procedure sounds logical, it probably will accept it. If it sounds unlogical, no matter what study you will present, people will not do it. So let's try to understand what's going on with implantation. So maximum fertility during one menstrual cycle is around 30%, and only 50 to 60% of all conceptions advance beyond 20 weeks of gestation. And what we have here, we have a blastocyst, we have a receptive endometrium, and this is actually a very delicate process or a symphony between the blastocyst and the endometrium in order to have the implantation process. The three major steps of implantation published recently in the New England Journal of Medicine, and you can see that the first stage is apposition of the blastocyst. The second one is the penetration of the blastocyst into the uterine epithelium, and then the third one is the complete embedment of the blastocyst into the stroma covered by the epithelium. So implantation is the rate-limiting step for success of IVF treatment. And the question is why we have approximately 70% of fertilization and quite a low rate of implantation, and whether it's related to the gamete quality, the embryo quality, transfer technique, luteal phase support, or time of implantation. So how can we get or produce or stimulate an optimal luteal phase endometrium? And is it possible to improve the implantation? So I'd like to speak today about local endometrial stimulation or local endometrial injury, and where the whole story started. It actually started in our unit at the Kaplan Medical School Hospital in Israel, in Rehovot. And it was part of a totally different research program. And what happened is that we worked with the Weizmann Institute, and we wanted to look what's happening in the endometrium within a group of patients who failed to become pregnant or the embryo failed to implant. So it was decided to take 4 biopsies to look at connexin 43 in the endometrium in the patient with repeated implantation failure. And what happened? The biopsy was taken 4 times in the cycle, on the day 8, 12, 21, and 24. It was taken with a pipelle with a very gentle biopsy. And the patients went through an IVF cycle following this cycle. And out of 12 women, 11 conceived in the following cycle. So this was the beginning of the story in 2003. It was then went into a randomized study of 134 patients, and it was published in Fertility and Sterility under the title, Local Injury to the Endometrium, Doubled the Incidence of Successful Pregnancies in Patients Undergoing In Vitro Fertilization. And you can see 134 patients divided into two groups. Treatment were in those who failed to conceive during one or more IVF cycle, and they randomly selected for endometrium biopsy or as a control group. And here are the results. You can see a significant difference both in implantation, in clinical pregnancy, and the rate of live birth between the two groups. And actually, it was doubled. The implantation, clinical pregnancy, and delivery was doubled between the control group and those who went into biopsy. Since then, 2003 until today, if you search the PubMed, the literature, you can find more than 1,000 papers published on this topic because of the very controversial issue, which I don't think there is any controversial here, but there is probably a controversial issue because of so many papers published in the field, whether to do a biopsy or not to do a biopsy, and what is the results. I just want to show you that during 2016, there were more than six papers that I detected very easily. One of them was published in Human Reproduction under the title, Endometrial Scratching for Subfertility, Everyone's Doing It. And this was a paper published by a group in New Zealand. And what they did something which is very simple. In New Zealand, Australia, and the UK, they sent out a survey to 143 public and private fertility clinics, and they asked who is doing the scratching and what's going on. And 83% of clinicians recommended endometrial scratching prior to IVF. Of these, 92% recommended endometrial scratching to women with recurrent implantation failure, and 6% recommended it to all women having IVF. So where is the evidence? And is there any evidence? So let's try to see why I think the procedure is very logical. And we can go back to a paper, or actually a letter published in The Lancet in 1993, again from a group in Israel, who treated a small group of patients with curettage, antibiotic, and steroids, and the pregnancy rate at that time during IVF was very significantly higher in this small group of patients. And then there were several papers showing that irritation of the endometrium increased pregnancy rate. And the first one is intrauterine injection of oil to the right uterus increased pregnancy rate. It was published in 1969. Then there is a paper called The Fertility Rates Among 109 Patients Following HCG were found to be 31%. Just going back to hysterosalpingographia, at the early days, I'm not sure how many of you here remember, we used to do it with an oil dye. And this caused irritation. It was very painful. Some of the patient has fever, but we found that following this procedure, some of the patients became pregnant. And there were a lot of papers actually trying to understand why the pregnancy is higher following hysterosalpingographia. And these are the reasons I found in the literature. Clear mucus plug, breakdown peritoneal adhesions, provide a stimulatory effect for the cilia. The iodine may exert a bacteriostatic effect, washes the ovaries from local toxin. But I think that the old medium caused some irritation of the endometrium, some kind of inflammation, which then increased the implantation rate. Then there is a paper published 14 years ago by a group in Egypt showing that if you use dummy catheter to transfer and then you transfer the embryo, pregnancy rate is increased. And I would like to suggest that this insertion of the dummy catheter causes irritation of the endometrium. Also, there are several papers, or not several, there are many papers showing that embryo transfer under ultrasound increased pregnancy rate. But those who remember how to do IVF before the days of the ultrasound, you know that it was very easy to put the catheter and the embryo into the uterus. So why the ultrasound increased pregnancy rate? I would like to suggest that the friction of the catheter while you push the ultrasound makes some irritation to the endometrium. So in general, inflammation and implantation are subjected to the injury of the endometrium, which cause movements or chemotaxis of cytokines, monocytes, macrophages, dendritic cell, and all cause proliferation, differentiation, and remodeling of the tissue. And going again to the group in Israel who did the initial study, they looked at different markers following the irritation of the endometrium, and they found that there is marked increase or significant increase following this biopsy with growth regulation androgen alpha, interleukin 15, and macrophage inflammatory protein 1b. And if we look to the uterus ret, you can see on the left side one horn of the uterus, which has an irritation of the endometrium, and you can see how it looked like 3 days after this was happened. And again, the group in Israel were looking at the inflammation process in the endometrium, and they published a paper quite not 7 years ago to show that during the process of implantation, there is a gradient of inflammation on migration of inflammatory cell into the place of the apoptosis and the adhesion of the blastocyst. So since then, as I mentioned to you, there were many, many papers published in the field looking at the irritation of the endometrium. And in 2012, there were 2 meta-analyses and 1 review paper actually showing significant increase in pregnancy rate following irritation of the endometrium. And this was also reconfirmed in another meta-analysis in 2015. And I just want to read to you the conclusion of this meta-analysis. Endometrial injury performed sometime during the month before the start of ovarian stimulation as part of ART improved the chances that a woman will achieve live birth and clinical pregnancy. If 26% of women achieve live birth without endometrial injury, between 28 to 48% will achieve live birth rate with this intervention. However, I cannot leave this stage without giving an echo to the opponents of the procedure. And one of the groups that actually object the procedure coming from IVI in Spain and leading by a very prominent scientist named Carlos Simon. And what they did, they looked at 5 randomized control studies published in between 1914 to 1915, 1 meta-analysis and 1 systemic review, and then concluded that the available data are controversial and no biological pulsatility exists to support the use of this intervention. They also said that endometrial scratching produce pain, cost money, and maybe they have side effects, and they mentioned Asherman syndrome, and they summarize these papers by think before scratching. I think it's very important to think before you do anything, and it's very important to think before you do scratching. But I don't think that this scratching causes Asherman syndrome. It depends where you practice medicine, where it costs money or not, where I'm coming from a country which infertility is defined as a disease, so no treatment costs nothing until you will have 2 children, so it not cost anything. And producing pain, this depends how you do it. If you do it very gentle, mainly at most of the time, it doesn't cause any pain. So in conclusion, I think that endometrial biopsy may trigger events that are involved in acquisition of uterine receptivity that may not take place in patients with repeated implantation failure in the absence of this mechanical intervention. And I cannot stop, I cannot finish my lecture without saying that there is a controversy about doing the biopsy. And there are lots of questions that we need to answer, and it's very important to answer. And after a decade, there are still no agreement on what degree of injury is required, the number of injuries to be performed, what day it should be performed, the time lapse between the injury and embryo transfer, and should it work in unselected population. Thank you very much.
Thank you, Zeev, for a comprehensive review, and you're more polite than I, so I will say it. Carlos Simon also obviously has a commercial interest in not finding this to work. Are there any questions? Yes, sir. Here.
We do a lot of scratching, and we have started to do the immunohistochemic reaction CD138 to look for plasma cells. And now we find that some patients really have a lot of plasma cells, and now we start to treat this. Have you experience with that?
No.
How do you treat it? Because we find them too, but we don't know how to treat them.
we give tetracycline for 10 days.
Yeah. But you don't see bacteria, I would assume.
No, but we do it again, and then they are gone.
They're gone. Okay, that's what we did too. But
there's another question.
Yeah.
Thank you so much for wonderful review. I have a question which is, like endometrium, it's not only about the issues you address, and this may be just an overview. What is your opinion for moved window of the implantation? Like if you are doing biopsy, are you checking, this is what we do. I'm not talking about the receptors, etc., just the microscopy. Do you check the growth of the pinopodiums? Are they growing appropriately to the progesterone supplementation or not? Do you have any experience of the double embryo transfer, and do you think it should be? And the second question, the thin endometrium. Do you have any experience in the growth factors for the endometrium preparation? Thank you.
What we're also doing with the scratching is that when we have thin endometrium, we're doing this scratching, and sometimes we see that the endometrium is growing. And we have quite a lot of success in some of the cases where the endometrium was very thin, and then we did it, the endometrium go up, and the patient become pregnant. Sometimes we do double embryo transfer, but it's not actually related to the endometrial scratching. It's just a procedure that we do from time to time. And we do endometrial scratching to almost all patients. Actually, patients are coming, reading from the internet. You know, they are very educated, and they come and say, we want to do an endometrial biopsy. So we do to everybody who asks for endometrial biopsy, even if we think that there is no any indication.
I have one question. I was at the SRM meeting, and there was a lot of talk about endometrial receptivity assays, which obviously require a biopsy in the preceding cycle. And it appears to me that that data that they're presenting may be confounded by the fact that they're performing the biopsy in the first place. What thoughts do you have on that?
He's a gentleman. Okay. Zeev, thank you very much. Friends, this is it. I would like to thank everybody. I'm really amazed how many of you are still here, and we greatly appreciate that. I want to thank especially the faculty, my co-chairman, especially David Albertini, who I understand wasn't very well the last 2 days and still has fully contributed. I hope we haven't too exhausted you, because we obviously have packed a lot into the program over those 3.5 days. I hope that we have succeeded in our goals in bringing together basic science and clinical medicine. That was one goal. In showing some new paradigms that we are seeing in the future. And we hope that you're going home with at least some thought about changing some practices that you got used to. And finally, we hope that we have induced you to think differently. And then till next year, have a safe trip home, and thank you for coming.